A cyst is a pathological space-occupying lesion with an outer fibrous connective tissue wall that surrounds a central cavity called lumen filled with fluid, semi-fluid or gaseous contents, which is not created by accumulation of pus. Internally, the wall may or may not be lined by epithelium. The cysts of jaw are basically classified into non-epithelial or pseudocysts and epithelial-lined true cysts, which is again classified into odontogenic and non-odontogenic fissural cysts. As per definition, the epithelial lining of these cysts originate from certain residues of tooth-forming organ. Let's see few of them in detail. The rests persisted after dissolution of dental lamina or glands of serous gives rise to odontogenic keratocyst, lateral periodontal cyst and gingival cyst. The reduced enamel epithelium derived from enamel organ which covers fully formed crown of unerupted tooth gives rise to paradental, dentigerous and eruption cyst. The third one is rest of malaces formed by the fragmentation of epithelial root sheath of Herdwig which gives rise to radicular cyst. In this video, we shall see about radicular cyst, the most common type of cyst in the jaw, which is otherwise called as periapical or apical periodontal or dental root and cyst. So what are epithelial rests of malaces? To know that, we shall have a look on the role of Herdwig epithelial root sheath. Herdwig epithelial root sheath is formed by combination of inner and outer enamel epithelium which further stimulates the differentiation of ectomesenchymal cells into odontoblasts and secrete root dentin along with the differentiation of periodontium. Once this function is done, Herdwig epithelial root sheath undergoes disintegration and some persist as dispersed islands of epithelial cells known as epithelial rests of malaces in periodontal ligament and pulp, even after the root formation is complete. Some of the rests become calcified in periodontal ligament as cementicles. The pathogenesis of radicular cyst is divided into three phases as initiation, formation, and expansion of cyst. How it initiates? In a carious tooth, if pulpal infection happens, as a result, bacterium will reach the periapical area from periodontal pocket or gingival sulci. Once the bacterial antigen enters the periapical tissue, it is recognized by antigen presenting cells which present the antigen to the effector T cells, results in activation of macrophages which releases lymphokines, ultimately proliferates the epithelial rests of malaces. Because of this conflict between bacterial action and the host defense mechanism, there happens destruction of tissue in the periapical region resulting in apical periodontitis which further paves way for the formation of radicular cyst. Cyst formation, the second phase, is supported by three theories. First is nutritional deficiency theory depicts when the island of epithelium expands, the central cells undergo necrosis and liquefaction degeneration leading to cyst formation. Coming to abscess theory, which states the nature of epithelial cells is likely to cover the exposed surface of connective tissue. Likewise, the proliferating epithelium lines the abscess cavity formed by tissue necrosis and lysis. Ending up with epithelial strand theory, which states a 3D ball mass is formed by the continuous growth of epithelial cells, where the connective tissue trapped inside the ball mass dissolves, resulting in the formation of cyst. Moving to the third phase as expansion, where the large number of osmotically active molecules in the cystic lumen makes it hypertonic compared with serum. As the cyst wall acts as the semi-permeable membrane, the water and crystalloids are freely allowed but restrains the passage of colloids, resulting in osmotically active molecules retained within the cystic lumen, resulting in the movement of fluid from the tissues into the lumen along the osmotic gradient, which increases the hydrostatic pressure within the cyst, causing it to expand in an unicentric ballooning pattern. There are two types in radicular cyst. One type is true cyst, which is independent from the root canal apex, and the second is base cyst, where its lining is closely associated with the root canal system. Clinically, the tooth has a necrotic pulp confirmed by electric pulp testing and its response to both hot and cold stimulus. The swelling is slow, progressive, and painless with no symptoms until it becomes large enough. It is rounded and hard in consistency. Later, when bone reduced to eggshell thickness, crackling sensation may be felt on pressure. Eventually, part of wall resorption happens, producing a soft, fluctuant bluish swelling beneath the mucous membrane. Radiographically, epicenter of lesion is localized to apex of tooth or with the lateral surface of root where lateral canals reside. There is a well-defined corticated border, round or ovoid in shape, radiolucent and unilocular, associated with dead tooth. Thanks for watching. Hope you will like my video. Please share, subscribe and comment.